So I'm very pleased to have one of a dear friend and collaborator for many years who had retired and came out of retirement today to speak with us. Dr. Terri J. Vrtiska received her medical degree from Vanderbilt University and dedicated the next 34 years to productive and successful career at the Mayo Clinic College of Medicine and Sciences as a diagnostic radiologist. Dr. Vrtiska's dedication to the care of patients was embodied in recognition by her peers with the Carmen Award of Clinical Excellence. She created and led for over 10 years the Clinical 3D Imaging and Post-Processing Lab. And as a longtime collaborator with the CT Clinical Innovation Center, she helped develop and translate state-of-the-art CT techniques into our clinical practice. Dr. Vrtiska is an accomplished and passionate educator and was recognized by the RSNA with their Honored Educator Award. Terri.
Wow, what a great morning we've had. This has just been tremendous to be back at Mayo and to see friends and colleagues and mentors. Thank you for inviting me, Cynthia. It's just been a wonderful experience. So I'll look forward to sharing with you the next 25 minutes, a little bit about the background of developing the 3D lab and kind of where that came from. And then I think later this afternoon, you'll hear more about where it's going, which is just an incredible opportunity as well. I love this quote that I recall from many years ago. Dr. Mellons, a professor of radiology at Harvard, said, "The radiologist perceives a shadow, sees a lesion, and imagines the man. The bedside physician sees the man, perceives the signs, and imagines the lesion. They practice from the outside in, and we from the inside out." And I think with the use of 3D, we're bringing that relationship closer together, especially as we look how we use those 3D images around communication with the patient. So I'll use three buckets here in the beginning with the 3D lab, the why of visualization of the CT data, and then as discussed, some of the improvements in CT technology that has impacted 3D imaging. So as shown earlier today, we go back in time, and this is mentioned several, our reason for being here back to 1973. And the famous picture, it's so wonderful to kind of meet people that were in that photo. Just a tremendous opportunity here. I'd take you now forward about a few more years to the year 2000. And that was about the year when I had the idea, how could we take what was transforming from the acres, really, for those of you who remember, of films we would have in the reading rooms. And as computers became more common, how do we present that more easily to our clinicians, to the surgeons, and even to our patients? So at that time, we had a scholarship committee who we could apply for time to work on projects. And the maximum amount was 15 days. And I requested 15 days to develop a 3D lab for the Mayo Clinic. I was awarded 1 day with a note on the column to say, I hope you can use this for seed time to create the 3D lab. And I think it was a very productive day that I spent, and to see where it is now with others being involved is just tremendous. So this is where we started, in the back of the GU reading room, a borrowed console, computer. And it was probably, I think there's a few techs here in the room, what was probably the most impactful for this was that not just the equipment we had, but the CT technologists were really volunteering their time to create these images. And when we first started, it took almost a day to create where we started was renal donors and to develop that in the back of what was the GU reading room on this single. And then we moved across the hall. There was a vacated scheduling office and used that for about a year. But the big thing then was we were given a dedicated 3D technologist position that we utilized in this space and used that for about another year till we moved upstairs here in the Gonda building to what was still an empty reading room. And the techs did design this and utilized it. And this was where the workflow started happening, where we would have protocol cases and start really seeing things flow through the 3D lab, as it was called at that time. There were 2 positions, and we were able to use several different protocols to make sure that we did the right studies, and just a tremendous group to work with. And probably one of the nicest spaces that we enjoyed until now, with it moving out to St. Mary's in a tremendous lab in the anatomic modeling unit, was a space, again, back at the Mayo Clinic building, that was designed by the technologists. We worked together to have schedulers and a real team that worked together very well and provided these images for many years in this specifically designed 3D space. So I would offer, as we're celebrating the 50th anniversary of CT at the Mayo Clinic, our gold anniversary, it's actually about the 25th anniversary of the 3D clinical imaging services at Mayo. So it's kind of a nice opportunity to celebrate that with you. It's hard to believe that 25 years has nearly passed since we did those first images. The next is the why. We've kind of discussed who and where and when these things occurred, but the why. And this was important to me as in developing the lab, was looking at clarity, the communication piece, and the care that we were giving our patients. And in terms of clarity, I look back at a image that I'm just thrilled to share with you, because you wouldn't know this gentleman. This was my anatomy teacher back in medical school, Dr. Jack Davies, a tremendous anatomist, did our cadaver dissections, and in the afternoon we would break for tea at 3 o'clock. And he was also a tremendous artist that could draw anything, not only with one hand, but with either hand. He was ambidextrous. And if we had a question about any anatomy, he could rotate the image and draw it from any angle you would question. So he would always give us, how's the left atrium related to the tricuspid valves? Oh, let me just draw you that. And with both hands flying, he would create these beautiful images. That impacted me for the rest of my life, and was really a tremendous impact in how do we create images that give a more precise view, better comprehension, a clear understanding of these complex anatomic and pathologic relationships. And that we see now today in the way that clinicians, surgeons, and even patients can share that information together. The second short story that I'd share with you is in communication. And this I vividly remember being in a patient room where a team of surgeons walked in, gave a very nice illustration. The woman had an elderly woman with a complex aneurysm of her aorta, talked about the risks, the benefits, her recovery, etc., and asked if she had any questions. She didn't, and the whole team swept out of the room. I stayed for a few minutes to get her ready for surgery, and during that time said, do you have any questions about this particular procedure? And she said, yes. What exactly is my aorta? And in that moment, I realized a lot of times patients, their understanding, the best skill set can be used to try to tell them, but a picture is truly worth 1,000 words. And maybe through the use of imaging data, we can bring patients into an understanding of the anatomy, pathology, as well as the treatment planning. And that is really where a lot of the 3D imaging started, was presenting vascular anatomy to our patients, whether it be an anatomy of an aneurysm and how the surgery was going to be performed with an open surgical intervention. And later, it was really key in the understanding of endovascular repair and working with our vascular surgeons. A real teamwork of how these grafts would be placed within patients, what the complications would occur, and how we could best communicate those findings through the development of the 3D lab and sharing of a depiction of their aorta and of the aneurysm repair that was going to occur. It was really a wonderful and productive relationship over many years with the feedback we would receive from them, and then how they would use these accurate measurements from CT to precisely create customized grafts for the patients that they were caring for. So just a huge impact of CT and the way we would visualize that information. And finally, care. The patient I recall from this was a young woman who was donating her kidney to her sister. And she was not at all concerned about this huge flank incision that she was going to have after the operation. What she was most concerned about was the tiny little catheter they were going to thread through her femoral artery and obtain these pictures. Deathly afraid of that. And that always struck me as people's understanding. But now, through the use of CT angiography and creating these images since earlier times where we used catheter angiogram in the past, the patients were admitted the night before, they required anesthesia, they were kept fasting overnight. These exams would take at least 30 to 90 minutes to acquire. Dr. Sheedy very well remembers these kind of practice. And after that, even 4 to 6 hours of bed rest. It's really remarkable when you think that now through the use of CT and creating 3D display, we can acquire a CT angiogram with a tiny IV catheter in the arm, acquired in the same day and within seconds, and the patient leaves the department immediately. So to complete this talk is what's been shown here so far is the improvements in CT technology and how that has had an impact on 3D imaging. And similar to what Dr. Yu said, there's been several developments that have been hugely impactful in how we can create our 3D images: low KV scanning, improved material characterization, decreased image noise, improved spatial resolution, and also the dynamic 4D acquisition that was developed several years ago. So when you marry the technological improvements with impactful image visualization, we can quickly see how these things have come together and improved care for our patients, including as a dramatic reduction in the IV contrast. We can see that with improved visualization of CT venography, with radiation dose reduction, with improved spectral separation, the accuracy of stone classification, especially in larger patients, and removing calcium, with improved iterative reconstruction, as was discussed earlier, better in-stent visualization in our fenestrated aortic grafts, and better image quality in larger patients. And one of the areas that I always loved was the improved spatial resolution, where we could better see these very, very tiny structures, such as the perforator arteries and reconstruction of the breast, the artery of Adamkowitz prior to thoracoabdominal aneurysm repair, and temporal bone imaging. And then one area that has been developed also is CT angiography, the dynamic studies and preoperative imaging, which might include lower extremity runoffs, AV malformations, and endovascular stent graft leaks. So when we look at these improvements, I'll just show a few examples in closing here. For example, with low KV scanning. This was an area that was really impactful for those patients that have vascular disease and oftentimes have associated renal disease. And what we found was that for some patients, we could just give this very small amount of contrast, which was hugely beneficial and reassuring to our clinicians. For example, this case with a patient with an elevated creatinine of 4, with normal being closer to 1. And the surgeon had wanted to see the anatomy of the left renal artery, where we can see here the occlusion of the artery and how that anatomy looked on a 3D imaging. So just using about 40 to 50 cc's of contrast, we were able to fully demonstrate this, and then the patient was able to have a successful operation with a venous interposition graft bypassing the renal artery and improvement in their renal function. As I mentioned, for venography, we could better visualize the veins. Here's a patient with an enlarged vena cava when compared to the aorta, and a depiction of the anatomy here, beautifully illustrated. Images from our 3D lab. And a common study that we would do was for young women with May-Thurner syndrome. Again, low contrast, low radiation in a young woman, but depict how the right common iliac artery would compress on the left common iliac vein, resulting in her lower extremity swelling. We did look at this in a research project in the CT Innovation Center, where looking at the large amount of contrast that we had been given for our CT angiograms, between 100 up to 200 cc's based on their weight. And then by adapting that with the low KV, we could quickly see how we could obtain accurate studies with basically a third of the contrast. And this was very successful and implemented into our clinical practice. And as examples of that, this particular study, as an example, which one used 140, which one used a third of that, 50 cc's, they basically are identical. And on the left is the 140, on your right is 50, and still have these beautiful depictions with the reduction in the KV, and then a third of the amount of contrast material that was used. Another example that the surgeons were just thrilled with was a patient that had the complication of a occlusion of their left renal artery after surgery, and really wanted us to limit the contrast. And one of our first cases, and we were able to successfully do that, depict where the artery was occluded, and then again showing the reduction in the KV, and then this fraction of the contrast that was given to obtain those studies. And the publication that we had, again, with the group based within the CT Innovation Center, which in conclusion basically showed that we were able to reduce the contrast by 2/3 for patients at risk for decreased renal function, and still obtain the CT and the 3Ds that we wanted to depict. We were also able to lower the radiation dose with the lowering of the average KV. And happily, the renal sparing CTA, as we called it, was the preferred imaging technique for the reviewing radiologists in 97% of the CTA exams. So a very successful research project. In terms of improved material characterization, this was a very nice case that we did for Dr. Harold Bjornsson, where it nicely showed how the calcium was not able to really show the narrowing that was by subtracting the calcium, showed the lumen of the aorta here. And he was able to successfully place a stent across that with resolution of the patient's symptoms for her lower extremity claudication by subtracting the calcium and doing what used to take a catheter-directed angiogram. We also were doing subtractions for lower extremity runoffs and depicting the entire lower extremities for tibial arterial harvesting is a very straightforward study and very happily received by our clinicians. Another advancement was improved visualization within the fenestrated graphs that were being developed here, and where the luminal visualization was better as we advanced and used a lower KV. See that lumens better, which is very important in early intervention if there's a problem with these graphs. And then, as I mentioned earlier, something that was just beautifully depicted by our CT angiography and these very tiny arteries. This particular patient had a bypass graft from her mid-arm to her distal arm that had this high-grade stenosis that is so beautifully demonstrated even on the cinematic display, as we see here. And one of the other successful outcomes was visualization of artery of Adamkowitz that we used in multiple patients preoperatively in patients with a need for a thoracoabdominal aneurysm repair, which often required an angiogram that would be a catheter angiogram and inject contrast in all of these thoracic and often the lumbar arteries to determine where this artery of Adamkowitz arose. And here again, we could acquire these in a few minutes and get that answer quite quickly. And there's a beautiful hairpin turn of the artery of Adamkowitz. And as a final example, the dynamic visualization of arterial flow. Several examples here where by getting a dynamic study, we could see the flow in this particular patient, an AV fistula in the right neck, that through the dynamic display, we could depict where that fistula was located and then was subsequently repaired. As a second example, there was a need for certain types of leaks within these aneurysms, didn't depict findings on a single CT. The aneurysm would be enlarging as we show here, but only through the use of dynamic display could we see the communication over time, in this case between the IMA and the lumbar arteries, and then this could be successfully treated with embolization therapy here on a axial and a sagittal view. And as a final example, a nice depiction of a pseudoaneurysm that had arisen from the left subclavian artery, and the communication wasn't visualized on the routine exam, but only by the flow seen on a dynamic study could we actually depict the arterial fistula and then provide the information to the surgeon, where he then placed a stent across that with resolution of this complex pseudoaneurysm. So in kind of gone over these three areas that I think help show how the 3D imaging has been impactful, married together with CT advancements. I mostly have showed vascular cases. My other passion was in renal disease, and I just think it's been a remarkable journey to see how all of the anatomy and pathology can be depicted through the successful advancements within CT and 3D imaging, whether it be renal stones and characterization of the type and location through CT, whether it be renal masses to show the size, the location, any complications, and share that again with the surgeons and the patients. And then finally, the 3D anatomy of arterial and venous vasculature. That was a large portion of my practice. So I thank you for your attention, and I hope you enjoy the rest of this conference. Thank you, Cynthia.